questions as well, so you can help me understand dementia better as well. Okay, so just need to learn how to use this thing. Okay, so I was going to ask you what your thoughts are on dementia, but I've kind of just gone and put the slide up. So, okay, so a couple of definitions. So one of them is from the Alzheimer's Society. So what is dementia, essentially, okay? So it is a set of symptoms that will include memory loss and difficulties with thinking, problem solving, or language, okay? The Oxford Textbook of Psychiatry defines it as an acquired generalized impairment of intellect, memory, and personality, but with no impairment of consciousness at all. So essentially, dementia actually combines your mental health problems, your physical disability, your terminal illness, communication difficulties, and financial difficulties and emotional difficulties for families and carers as well. Okay? So just a couple of statistics now. Obviously, dementia is actually a global concern, okay? Now, figures from Dementia UK suggest that about 850,000 people within the UK suffer from dementia currently, okay? Now, it is predominantly age-dependent, so the older you grow, the more likely your chances are of developing dementia. However, about 42,000 people from that 850,000 will develop an early onset of dementia. Now, what do I mean by early onset? What I mean is patients the age of 65 and under will develop dementia as well. So as you can look at the statistics, about 1 in 1,400 between 40 to 64, to 1 in 6 to those aged 80 years of age or over, really. In my experience, the youngest I've seen is actually aged 52, but obviously that's in a secondary care setting. So when patients come to you in a secondary care setting, they've already had 1 to 2 years of Alzheimer's disease or any form of dementia to start off with anyway. So at least you're looking at 50 years of age. Obviously, according to the Alzheimer's Society, the figures for UK are supposed to go to 1 million people within the UK by 2025, okay? So a lot of people have actually asked me, what is the difference between Alzheimer's disease and dementia? What do you think the difference is? Any thoughts?
Alzheimer's is part of dementia. It could be the Alzheimer's is one
subset of dementia?
Yeah, of dementia. So
yeah.
the headline is dementia, and it could have other things as well. That's what we understand.
Yeah, correct. That's right. Often, I have seen the words Alzheimer's disease and dementia used very much interchangeably, but essentially you're right. So if we actually go to the next slide, you'll see that dementia is an umbrella term. No doubt, Alzheimer's disease is predominantly, I would say 60 to 62% of people will present with Alzheimer's disease, so it's predominantly the one. But however, there are many different dementias, okay? So the words should not be used interchangeably, really. Okay, so Alzheimer's disease actually was named by a doctor, Louis Alzheimer, in 1907, and he was actually looking at a brain pathophysiology of a lady called Augusta D. She was actually 51 years old, and she was actually suffering from a dementing type process. And when he looked at the pathophysiology of that brain is what he named as Alzheimer's. So that's how kind of the name came about, really. Okay, so how does Alzheimer's disease actually happen? So we don't actually know how Alzheimer's disease happens. What we do know is we've got protein clusters that kind of build up, and they build up into tangles and plaques. And eventually what tends to happen is those tangles and plaques will cause neuronal degeneration, which eventually will lead to brain shrinkage. And in the next slide, I will show you the difference between a brain of someone who doesn't have Alzheimer's disease as opposed to a brain of someone who does have Alzheimer's disease, and you'll see the difference there, okay? What we need to remember is Alzheimer's disease is a gradual onset, okay? The second most popular one, as you can say, is probably vascular dementia. And about 17% of people will present with vascular dementia. Now, surprisingly enough, in vascular dementia, actually, there's nothing wrong with the brain. There's actually nothing wrong with the brain. Whereas in Alzheimer's disease, we've got all these plaques and tangles that build up, so there's something wrong with the brain. But in vascular, there isn't anything wrong with the brain. There's something wrong with the blood vessels that actually supply the blood to the brain, really. Okay, so we'll kind of, if anybody has got any questions about specific types of the dementias, then you can come and see me, we can discuss it more. Yeah?
So when you mean early onset, sorry, so What is early onset? How do you know that this is early onset? What symptoms you...
So early onset, what I mean by early onset is basically patients under 65 years of age.
Yeah.
So anyone who comes to us under 65 years of age is what we say early onset dementia.
Fine. So what symptoms you notice in early
Very
onset?
much similar, literally, very much similar to your normal late onset, basically, of dementias. However, the only difference is in early onset dementia, it's a lot more aggressive. That's number one. Number two, patients develop the more rarer forms of dementia. So things like Huntington's, you probably see a lot more in the early onset dementia as opposed to you'll see in the late onset dementia. Okay? Also familial Alzheimer's disease, so more the genetics form of things, you'll see probably a lot more in the early onset. But the signs and symptoms are similar, if not the same. It's just a little bit more aggressive. Yeah. White matter diseases. So basically, it's kind of like, how do I describe it? It's more like when you have your plaques and tangles that build up and they form into the tau proteins. That's kind of what we mean by white matter diseases. No. Yes?
And how do they know 2005 grows to 1 million?
2025.
Yeah.
Statistics.
How would they just now giving that big number in history? How do you explain that?
I'm not really sure, to be honest. I kind of went with the Alzheimer's Society research that they do, and obviously they've got quite a lot of people who do research along it, so that's probably how they know. I'm assuming they probably look at the statistics of people in the past, and as the years go on, how many people there are, and they probably deduce that numbers, really.
On the fact that life expectancy is going to reach 80. So
Yeah.
according to your statistics, people over 65, between 65
Well,
and 80
yeah,
are
will
more
go up.
susceptible.
Yeah.
Therefore, the numbers will go up. So
Yeah.
you just tie those two things together. And
They
get
probably do, yeah. Having said that, though, interestingly, in Sweden, and their statistics are, quite robust because they've got, documents for everything. In Sweden, actually, the older you grow, the less likely your chances are of developing dementia, interestingly. Those are the statistics which are undisputable because they've got records for everything. So it's quite interesting, actually, yeah. Okay, so what do we think are the risk factors of developing dementia? Any thoughts? Genetics. Okay. Obviously something we can't control. Yeah? Anything else? Diet. Okay, yeah. So what's good for the heart is good for the mind? Anything else?
I thought it was just age.
Age. Yeah. So far, the older you grow, the more your chances of developing dementia. Not according to Sweden, but generally. Anyone else? Stress, okay, could be a factor.
As far as physical fitness, so the blood supply to the brain. Better,
Yeah.
more physically active.
Yeah, so in vascular dementia, actually, which I didn't mention, which I probably should have, is the more you have, initially vascular dementia was actually known as multi-infarct dementia, which is kind of multiple strokes. But now we know that even one big stroke can lead to a vascular dementia. So obviously, as you know, kind of keeping well and keeping healthy reduces your risk of actually developing. Okay, so if we look at the next slide, as you can see, normal and Alzheimer's, as you can see, the brain shrinkage, yeah? Okay, so risk reduction. Interestingly, though, if you look at number 4, challenge your brain, there's some really good evidence nowadays that the more kind of you keep your brain stimulated, the less likely you are of actually getting dementia. So things like Sudoku and playing, doing puzzles and things like that apparently is really good for risk reduction. And interestingly, a colleague of mine actually said to me that, if you are a right-handed person, say if you're a left-handed person like me, I should do things with my right hand or try to do things with my right hand because that will make my brain work a lot more. Worth a try. And that's, again, really important for us to remember is that we don't know how it happens. We don't know what the pathophysiology is. There's still a lot of research that's undergoing. So what we can do is most experts will agree that this is the kind of things we can do to reduce our risk. Because dementia, as we know, is not reversible. Okay? Is there a way I can go back slides? Yeah, okay. Yeah, oh yeah, fab. Okay, so if you look at other dementias, I've actually put down pseudo there with a question mark. Now, pseudo dementia is basically conditions that sort of mimic the signs and symptoms of dementia, but it's not actually true dementia. So something like a space-occupying lesion, which is something like a tumor, but it's not a tumor, could mimic signs and symptoms of dementia. Interestingly enough, though, depression is so debatable because if you look at depression, depression can mask the symptoms of dementia, but depression could also be a pseudo-dementia in itself. So we have a patient, for example, we had a patient anyway, who came into us a secondary care setting, okay? And she is severely depressed at the moment, but she also has got some really interesting signs and symptoms of dementia as well. And currently, we're not sure whether she's actually got dementia or whether it's severe depression. So we're currently treating her for severe depression. And if that doesn't work, then we will start her on dementia medication. Because if we actually look at the diagnosis and make her do the mini mental state examinations that happen, she will fail those exams, primarily because she's got the signs and symptoms already. But let's see if we can actually try and treat the underlying problem. She's really interesting, really. Okay, right. I think I went too fast. Okay, so what do we think are the general signs and symptoms of dementia currently? Any thoughts?
Loss of memory.
Somebody give me the obvious.
Loss of memory.
Loss of memory. Okay, so actually interesting you say that because loss of memory is what we call forgetfulness, really, isn't it? But when do you start differentiating between what is normal aging and what isn't normal aging? Because forgetfulness is normal aging. I mean, I forget things. I mean, I'm sure there's a name that I was supposed to remember, but I can't remember now. So how do you differentiate? What is normal aging? What isn't normal aging? And often family members or carers will say, but we thought it was just normal aging, you know. Initially, we just thought she just forgets things because it's just how it is when you grow older, which is true. When do you start differentiating that? Does anybody know? Forget recent things? Yeah. So that is one of the key indicators for Alzheimer's disease as well, actually, that you start to forget recent things. But you forget recent things even as part of normal aging.
In the same conversation you're having, you forget number of times.
Number of times. So repetitive, isn't it?
Yeah, repeating the same thing again.
Yeah, so when it's basically when your family and friends start to see a recurrent pattern or start to see that this is becoming a problem, but you yourself as the patient don't actually see that as a problem, that's when it most likely is not normal aging, okay? Forgetting routines. So to be honest, interestingly, there's a difference between, what I normally tend to say is there's a difference between having your, forgetting where your keys are, or having your keys in your hand and then forgetting what they're for. Yeah? Okay. So now the signs and symptoms, general signs and symptoms of dementia. We're talking very general here, okay? In general signs and symptoms of dementia, you tend to forget your short-term memory, but you will recall more past events. And as the disease progresses, in the kind of late stages, you won't remember anything. Okay? So it's very progressive. Anything else that we can think of apart from memory?
Physical coordination.
Physical coordination. Okay, so loss of cognition. Yeah? Anything else? Anyone else? What else would you see someone with dementia? Education. Agitation. Okay, so changes in behavior. Yes, that's correct. Now that's a big one actually. So changes in behavior. So as you can see, patients with dementia will exhibit behavioral changes. So you will see them getting irritable, you'll see them getting depressed, you'll see them very agitated, you'll see them very aggressive. You probably see them say to you that we're seeing things that are not even there. It's what we actually term it as behavioral and psychological symptoms in dementia. Very interesting report actually written by Subi Banerjee on how to manage behavioral and psychological symptoms in dementia actually. And he looked at patients in care homes and the use of antipsychotics, so medications for psychosis, in managing aggression and agitation in dementia. Because of his report, I ended up having to rewrite the whole PPSD guidelines for my trust, which took me a good part of 6 months, actually. So let's look at the dementia general signs and symptoms. Can you all see that, actually? Yeah. Just before we do that, actually, going back, risk reduction, I forgot to mention smoking is one of them. It's primarily because the picture would not let me have smoking and all that sort of stuff on there. Apparently lack of space. But so smoking is one of them. It's obviously good for your, not good for your heart basically, or your lungs. And obviously alcohol, and I would like to think nobody drinks here, but it is supposed to be within recommended limits, and obviously do not overuse the use of alcohol, because what tends to happen is when you drink or overuse the use of alcohol, you can end up having a thiamine deficiency, and that a kind of severe thiamine deficiency will lead to Wernicke's encephalopathy, which is reversible, but then you end up having alcohol-related dementia when you have Korsakoff psychosis. Okay, and that's not reversible, and that actually is drugs as well. Yeah, so things like black mamba can really affect the brain. And if eventually, I mean, I remember actually I did some work in prison where we had some patients who were taking black mamba, and it ended up being irreversible psychosis. There was nothing we could do to help them, and the signs and symptoms were exactly like how you'd have someone with dementia. Probably worse. Okay, so...
Did you say smoking was a good thing?
No, I said it's not a good thing. Yes.
Sorry, just adding on to the topic of drugs, is there any evidence that suggests that there is a correlation or an existence really of patients developing psychosis after taking marijuana?
Yes. So obviously, like marijuana, illicit substances, so yes, it can, because it's a brain damage, isn't it? It can affect your brain. So yes, there is. There is good evidence around it, actually, which you don't actually advocate the use of marijuana at all for that reason, because it can exacerbate psychosis. But again, it varies from patient to patient and depends on how much you actually take of marijuana as well. But we are looking at long-term brain damages for taking illicit drugs, yeah?
What about shisha?
What about shisha?
Because that's more relevant in this setting.
Yeah. I don't know, actually. Shisha is what? Tobacco, nicotine? That's kind of what we're talking, isn't it? So nicotine, okay, so nicotine actually, as you can see, is kind of what we have in cigarettes, yeah? Nicotine will act on, I'm going to probably get a little bit sciencey and technical here, but it acts on nicotinic acetylcholine receptors. Okay, now you have them in your brain, you've got them in your heart as well. It can probably exacerbate more cardiovascular conditions, which will eventually lead to vascular dementia. When I'm not saying that it would lead to vascular dementia for everybody, okay? I'm talking about the overuse of it here, yeah? So dementia, again, general signs and symptoms, so poor, decreased judgment. Again, all these signs and symptoms, changes in personality, will depend on the area of your brain that is affected. Okay? And everybody's journey on dementia will be different because every person is different. These are just very general signs and symptoms. It's a really key thing to remember here, actually. Okay? Okay. Right, so this is where I need you all to get a lot more involved. My mum is finding day-to-day tasks more difficult. Her memory is quite poor. I believe she has dementia. But what is the point of her going to her GP to confirm this if there is no cure? What are your thoughts? So what I want you to think about here is what is the importance of an early diagnosis? Why do we need an early diagnosis? That's number one. Number two, I want you to think about what I've just said, that it's not reversible. Okay? And eventually, this patient, in their late stages of dementia, will be totally dependent on you. Okay, so they could potentially even be incontinent. Okay, so I want you to think about that and think about why do we think it's important for us to have an early diagnosis? Okay, so dementia is a progression of disease. Okay, we can't stop that progression. What we can do is we can slow it down, okay? Did you raise your hand up?
Yes, that's what I think.
Okay, right. Anyone else? Why is it important? There's a couple of points here, and I want you to think slightly outside the box. It's not reversible. What are we looking at towards the end? What are we looking at towards the end? Long-term care. Right, okay, long-term care. 24-hour care, yes. And in that 24, what else? What do I need them? Why do I want them to have an early diagnosis? And in the early stages, they have an insight into their condition, yes or no? They have an insight into the condition, right? So in the early stages, whilst they still have insight into their condition, I want them to be involved in their care, do I not? I want them to be involved in their care. And because I want them to be involved in their care, an early diagnosis is really important. So a couple of things. A, we want them to improve their quality of life. Yeah? B, I want them to be involved as much as they can in their care. C, we're looking at an advanced directive, are we not? So basically the patient, once they still have insight into their condition, can actually say what treatment they would like or what would they want for themselves. And D, as much as I hate to say this, but a power of attorney. Yeah, to take over decisions of their care when they no longer have insight into their condition, and I guess also sorting a will out if they need to, get their finances in order. Yeah, so that's the importance of an early diagnosis. And also essentially an early diagnosis will also help us because the earlier the diagnosis is, the more the friends and family will know about the condition, the more they'll read up about it, the more support services will be around, which means that eventually it's better patient care, isn't it? So that's the importance of an early diagnosis. Also, key thing to remember, when someone's diagnosed with dementia, legally they have to let the DVLA know. Okay? Okay, so this patient has now gone to their GP, for example. They've been diagnosed with dementia, they've been given medication, all the tests are done. Okay, so I won't discuss medication so much, because I'll probably be here all day. But at home, how would you manage this person? Now, I've picked out key things: environment, behavior, and communication. So environmentally, how would you manage that person? So just think about the signs and symptoms we've kind of discussed. We've discussed their mood changes. Environmentally, how would you, if you are a family member, a carer, how would you deal with it? Keep her occupied and? A lot of attention? Okay, fine. Fine. You can just merge all the three and just give me or whatever answers you feel like, really.
Changes to the physical environment.
Yeah, you need to make changes to the environment. How would you do that? And what sort of changes are we talking?
Old rails
Or rails, yeah.
or having the things which switch off after a little bit of time.
Okay,
Like
yeah.
it's just-
Yeah. Do you want to say that with the mic on? Because I'm not sure if everybody heard you.
Yeah, I mean, try to make sure that when they forget to say put the cooker off or something, it will switch off or whatever.
Okay, so fire hazards.
Fire hazards,
Yeah.
physical hazards, in terms
Physical
of
hazards.
falls and so
Yeah.
on. Yeah.
Anything else? Anyone?
Set up a group of friends and family who visit them on a regular basis. They're not alone.
Yeah, so they don't feel alone. Yeah.
And the main carer, if it is the spouse, will get a little more pressure. So the spouse needs to be supported by taking them away from the patient. And also to have extended family visiting more often, so the person they feel like they have the social interaction. It just helps them come to terms with.
It does. It really does. Yep. Anything else? Okay, so one thing to remember is patients with dementia do not like unfamiliar surroundings. Okay, so try and make that surrounding as homely as possible for them. Okay, don't introduce new things if they don't need it around. Communication-wise as well, interestingly though, how would you communicate with someone with dementia? How would you communicate with someone with dementia? Would you be using like very long sentences?
No.
Cut them down, yeah?
You should never question them either.
You should never question them.
Yeah, I don't think, I wouldn't really say why are you doing that?
Okay.
Because they won't know the answer.
Yeah,
So
yeah,
you're
yeah.
challenging her. and-
You're challenging her. Yeah, okay. Anything else? Sign language. That's if they know how to interpret sign language. No, it's important to, yeah, it's important to communicate with them because even though they may find language and communication difficult as they go along, they might find it difficult to kind of find the right words or things like that. It's, you know, they do like communication anyway. Okay? One thing to remember is that you will find that they repeat themselves. They'll really repeat themselves. And often family members and carers will always say to us, it's very frustrating. And it can get very frustrating. Because imagine if I say to you, I have seen you in town, and you say no, and I repeat the same thing, and I'm adamant, you'll find that very frustrating. But one thing really important to remember is that that's real for them. They genuinely have forgotten. So there's no point aggravating them and arguing with them, because it's really important to remember that is reality for them. Okay? We're just scratching the surface here on the psychological and social interventions, okay? Obviously, someone like an occupational therapist, if anyone wants to know on how to manage this, we're probably the right person to give more information on. And I'll give you the reference sources and signpost you to the right people towards the end. Oh, okay. Sorry? Oh, pointed there? All right. I am doing that. No? All right, there we go. Good. Carer support. So I care for my mother. She was diagnosed with Alzheimer's disease 8 years ago. I promised I would look after her, but I am exhausted. And I often feel that I cannot carry on anymore, as she does not know who I am or where she is. It feels pointless carrying on. What can I do? So key things that I want us to kind of a little bit discuss about here is the carer support, okay? So how exhausting is it for the carer? Carer burden, carer stress, and also the stigma revolved around it. So any thoughts? Any thoughts from anyone? Yeah. So first of all, it's acknowledgement that there is carer stress involved, yeah? Any thoughts around this particular scenario, place yourselves in the shoes of the person who is the carer, which often tends to be the family member. So obviously, eventually, as dementia progresses, the patient will lose their long-term memory, and eventually they will not recognize who you are. So you are essentially, say if you are looking after, in this case, say if the woman is looking after her mum, eventually her mum will not recall who she is. Her mum's not going to know who she is. But she's just looking after her. And as you go along, you will see that this patient becomes fully reliant on the daughter, on the carer, essentially. And you have to help them with, issues like incontinence, malnutrition, their mood changes, their behavior changes. There's a lot of things to think about here. So think about that carer burden. Any thoughts? Get help, yeah? Okay, so I'll give you a scenario, and this is actually a true story, and that's why I actually put this on. It's about stigma, okay? So there was a family where the grandmother was very late stages of Alzheimer's disease. And when I say late stages, she was severely impaired, okay? So when actually we got there, we saw at their house that the granddaughter is actually cleaning the feces of the grandmother, severely impaired. Upon speaking to the family, they were by no means going to acknowledge that she had Alzheimer's disease. By no means did they want her to receive that help, because by no means did they want anybody to know that she had Alzheimer's disease. Okay, that was no chance. Obviously, if she had diabetes, we'd go to the doctor straight away. But any kind of condition like this, we're not going to go to the doctors about. So it ended up being that the daughter-in-law of the house, the onus was on her to look after the grandmother. So she had to leave her job and actually look after the grandmother. Okay? No support whatsoever. She probably has had no training at all. She's probably on her own looking after her. That almost becomes a burden for her. Okay, so think about the patient. That's unfair to the patient. Very unfair to the patient. Be it the granddaughter who's probably not had any form of support at all, is probably having her own problems, and it's not uncommon to have carers who undergo depression because they're not receiving the right support, because almost it tends to be that your family member is the person who's looking after the person with dementia, okay? And often it tends to be that, how can I not look after my mother? That feeling of guilt. How can I say that, I feel almost embarrassed to say I cannot look after my mother, but there's no shame in asking for help. There is help if need be. Okay? There's a 94-year-old lady who's looked after by a 72-year-old daughter who probably has got physical health problems of her own and is really struggling. If you can't look after yourself, you will not be able to look after the person with dementia. Okay? Now, Carers Support UK is actually very good. It really supports carers and helps them look after their own physical health, and that's really important. So what do we need to do? We need to make our community dementia friendly. And how do we do that? By signing up to become a dementia friend. Okay? And Dementia Friend actually is really good, because I just recently signed up for Dementia Friend actually. And they show you a whole host of videos about what it's like to understand what dementia is. And then you kind of spend time with someone with dementia, so you have an understanding of what it's like to live with dementia. Because unless seen, we don't actually know. Yeah. It's not working for me. I've got 2 videos I actually wanted to show you. So the first video is just a little bit about activities of daily living. And I think, as the gentleman at the back mentioned about how can they forget me, you will see that a lot more. Can we just play the first video, please? Okay, so this video is a little bit longer, but before we play it, I just want you to know that this video will amalgamate a lot of the signs and symptoms that we discussed. So it's not just about memory loss, and she will go on explaining that, and she'll also talk a little bit about Dementia Friend as well, so I'll give you more insight. I can play that now, it's fine. So yeah, signing up to a Dementia Friend would be very useful if you want to get a bit more insight on what it's like to live with dementia. Okay, so useful resources. So the Alzheimer's Society is actually a really good reference source, okay? And they provide lots and lots of useful fact sheets and information. And if you want to know a little bit more about carer support, you want to know a bit more financial support, a bit more about advanced directives, power of attorney, anything to do with the DVLA, informing them, you can find everything from the Alzheimer's Society and actually signpost you to the relevant resources. There's also normally support groups around your areas as well. And when you type in your postcode in the Alzheimer's Society website, they actually come up with lots and lots of places around your area. Then obviously there's Carers UK, that's very good as well, which provides help for people caring for people with dementia. And then there's an interesting book on Iris, a memoir of Iris Murdoch. It was actually written by her husband and how he coped with her having Alzheimer's, and they actually made a movie out of it as well. That's pretty good. A majority of you probably watched The Notebook. It's not probably a right indication of what dementia and Alzheimer's is all about, but interesting anyway nevertheless. So I hope you found this session useful and have a good understanding of what dementia is. We've just scratched the surface, to be honest. There's still a lot of ongoing research currently. Currently, where I'm actually overseeing some trials on new drugs on dementia. It's still in its infancy stage, but hopefully, you never know, if the clinical trials go ahead well, then maybe we'll get something new for dementia, hopefully, with obviously NHS funding at some point. But thank you. Thank you for listening. And if you've got any more questions, then just come up to me and ask me.
Before we end, could we just take some questions?
Yeah.
We have a few minutes for questions.
Yeah.
Slowing down dementia. The drugs, do they have any side effects?
The medication. Okay, so the medication that we've got for dementia currently are of 2 main groups, okay? And the ones we are trialing, which we can't really discuss anyway, but the ones that are currently licensed for dementia, do they have any side effects? Is that your question? They do have the general side effects, so they do have your kind of peripheral side effects, so they normally have like GI side effects, so we're talking nausea, vomiting, diarrhea, things like that. They do have kind of more side effects on like cardiovascular side effects later on, but it's not I kind of feel like I'm scaring you right now, but it's not a side effect that everybody will get. I mean, I've got patients who have taken dementia medication for over 7 years and I've never seen it to be a problem. It's actually helped them slow the progression of the disease. So when we actually give medication to people, key thing to remember is no medication goes without side effect, okay? But it's risk versus benefit. And over here, the benefits will always outweigh the risk. Yes.
Do you treat them like sort of with herbal things or any traditional way to deal with this matter, because they don't have a side effect? The reason I'm asking, it's a doctor who's going back to the sort of medicine of sunnah, and he does. Through that, he just gets rid of cancer, MS, and then this problem.
Medicine of what, sorry?
Traditional medicine.
Okay, so herbal. Are you talking about herbal? Or?
Well, it's not only herbal, the sort of how to, the diet has to be there. Do you ever use that in your...
Yeah, so I mean, diet and things like that, lifestyle factors, something we always encourage, you know, and as I mentioned previously, are the biggest risk factor eliminators, to be honest. But when you're talking about kind of, are you talking about herbal as well now? As well as diet and things like that? Yeah? Okay. So just to cover a little bit about herbal medication now is, as a clinician, pharmaceutical medication that we give, they undergo robust clinical trials before they come into the market, okay? They undergo preclinical trials before they come into the market, before they actually undergo clinical trials. It takes a while before a medication is licensed for an indication. So by the time that comes into the market, we have a lot of information about that medication. We will probably know about the yellow card reporting, any form of adverse drug reactions. We will know that, well, majority of the times anyway. And if it's a new drug, it'll automatically go up on the yellow card anyway. So we report it straight away. Whereas with herbal medication, we don't always have that sort of information. And herbal medication always, also remember, is when you go to a pharmacy and you actually look at the ingredients at the back. So each brand will probably have a different active ingredient, kind of milligrams or grams. So they're not always consistent. That's number 2. Number 3 is, as clinicians, as healthcare professionals, we actually go through National Institute of Health and Care Excellence. It used to be called National Institute of Clinical Excellence. Now it's National Institute of Health and Care Excellence. My memory is not very good. NICE, basically. And they actually look at all the studies that have been carried out, including herbal medication and everything. And they will, once they look at the study, they will look at the evidence behind it, and they will critically appraise each study and put it up as whether it's robust or not. And after that, they'll produce guidelines on it. Now, herbal medication is not actually in the guidelines. Yeah? And once they produce those guidelines, we as clinicians end up following those guidelines. So from a clinician point of view, I'm not going to dismiss herbal medication, but I'll also not be an advocate of it. I hope that answers. No experience on that. It's not really in the guidelines for any clinicians in primary and secondary care setting, so we don't advocate the use of it. Because we don't know enough about it, and that's because there's not enough data out there on it. We will go with what we have enough data of, because we know that when we have an adverse drug reaction, we know what we're looking for. With herbal, we wouldn't really know. And a typical clear example of that would be, slightly off topic, but St. John's wort for depression. Now that, first of all, the ingredients vary between each boxes, and also they interact with your standard depression medication, and they interact with a lot of other medications. So we don't know enough information about it. I hope that answers that. Enough anyway. Anyone else? Yeah.
Some will be slower. So how would one know that this medication has slowed the progress, or is just...
Okay, so the way we would know is when we don't see a deterioration in the mental health, in the status of that patient. That's how we know that the disease progression has kind of slowed down, and the medication is keeping it at a steady progression down. Okay, that's how we would know, when we don't see any degree of deterioration. And what we do is what we did with one of our patients is we actually removed the drug, and we saw deteriorations. We put him back on it. And the only reason we removed it is because the drug is normally licensed for 18 months only. This patient has been on it for 7 years. And once we took it off, it was a rapid decline, so we had to put him back on it.
And at what stage of Alzheimer's or dementia you would see really the changes in the brain? I mean,
the changes in the brain have already happened for it to be diagnosed as dementia anyway.
So initially on a scan, when would you see some changes on the brain scan?
So I don't know much about the scans, to be honest, because I don't really get involved in the diagnosis side of things. But what tends to happen is you'll go to the GP, they'll do blood tests on you, they will send you for scans, they'll send you for MRIs, they'll send you for CT scans, and then they will see if there's any plaques or tangles in the brain. Interestingly enough, though, that you mentioned these scans, There is a recent, I don't know if you guys have heard of this recent machine that's out there in the Queen Elizabeth Hospital that actually looks at the neuroimaging of someone's brain, okay? In that neuroimaging, they'll see if the brain has got any plaques. If you've got plaques in your brain, it kind of, they say that basically, they kind of diagnose it in advance that you may get Alzheimer's disease in the future, or actually they're confident that you'll get Alzheimer's disease in the future. So I think they are advancing the scans now, but the question is, would you really want to know? Because you don't know when you'll get it, at what age you'll get it, and it could just destroy your whole quality of life. Because that information is not, you can't unknow that information then, can you?
When you have the tablets, so the dementia person, they remember everything when they have these tablets. Is that what you're saying?
Remember?
Yeah.
No. Okay, so do you want to just answer that? Okay. What do you mean by they remember everything?
You know, they've got dementia, and you give them tablets to not to go like, you know, far. So now what happens when you give them tablets?
When we give them tablet, we're just slowing the progression of the disease down. So essentially,
Very, very quiet, isn't it? It's
yeah, it slows the progression.
much, really. It becomes, I don't know. No,
I don't understand what you're asking
to a
me.
dementia person, they don't talk much. They become very quiet, actually.
They don't talk much.
Yeah. They forget to talk at the end.
They do forget to talk, but that is a sign of dementia.
But then when you give a tablet, how does it happen?
The tablet slows the progression. I wish I had a flip chart or a piece of paper and I could have drawn for you. Alzheimer's, just imagine, it's literally goes down. This is Alzheimer's, okay? It literally starts from the top and you're going down. When you give medication, you're just slowing that going down. You're just slowing it down. That's all we're doing. And basically, essentially, we're just improving someone's life expectancy. Yeah, that's all we're doing. We're not stopping the disease. There's no cure for it. But we're just slowing it down. So instead of 1 year, we could give somebody 2-3 years. That's all it does.
Is this modifying the drugs?
Yeah. It just slows the progression down, okay? There's no cure for it. Yes.
Sorry, there
No,
is a
carry
cure
on.
for it.
There is? Okay. Please
I think,
enlighten me.
No, I just really thought, you yourself perhaps could suggest to really go back to traditional way of treatment, which is the herbal. And then the real teacher was Ibn Sina, if you ever heard of him.
No,
We
I
call it
haven't.
Avicenna. They teach his herbal things in Norwich, in a university. But anyway, in Iran they're doing it, so it would be good to look at into this. If you want me to provide some material, then I could.
Yeah, by
Yeah.
all means. And
And
obviously, I mean,
I'm so amazed this doctor really doing this, and I couldn't believe it when
what
I
I would suggest for that doctor to do is, because Alzheimer's UK actually is looking into research, he could just easily contact Alzheimer's UK and actually provide them with that information. If they think it's robust enough, they probably will give it a go and have
Well, I hope
trials
so.
around it.
Okay.
Because that's what we're looking for, really, aren't we? Anyone else? Sorry, any questions? Who's got questions? Yeah.
Yes, so because you're involved in research, I'd like to know a little bit more in terms of, because now we've already been told that people from the Asian community are more susceptible to diabetes, and it's been a proven fact.
Yeah.
So I'm worried now. Are you able to allay my fears? This example that you gave in the middle of your talk
Yeah.
about
Risk
the
factors.
family looking after
Yeah.
and not letting their neighbors know that the elder person in the family, who everybody was depending on before, cannot look after themselves. Now, obviously, that's a social taboo,
Yeah.
right? So, are you now going to make me more fearful of being brown by expanding on that example? Was that an Asian family?
The one I was telling you about, was it
Yes.
an Asian family?
Yes.
Yes, it was an Asian family.
Okay, so in that case, can I take you a bit further on this?
Yeah, go for it.
Because a lot of us have already had
Yeah.
elders. My own
Yeah,
father
yeah.
was affected, and other people
Yeah,
sitting
yeah.
here. So the education in my case was this: that a social worker came in, sat me down with a cup of tea, and said, "You are not responsible for looking after your dad." Now, that was a revelation at the time.
Yeah.
This is going back maybe
Yeah.
10, 15 years.
Sure.
But now the second generation probably deals with this a little bit better, because clinicians and people like you are there for a reason, and we realize that as we go on. But now tell me, is the Asian genre more susceptible to Alzheimer or not?
I think it's not just the Asian. I mean, personally, I haven't seen any studies around to say that the Asian population is more susceptible to Alzheimer's. It is actually a question I asked a few experts before coming here, because in my experience in the secondary care settings, I've seen a vast array of patients. I've seen Asians, I've seen Caucasians, I've seen Afro-Caribbeans. Yes, no doubt, as Asians and Afro-Caribbeans, we are more susceptible to mental health conditions. That is a proven fact. Afro-Caribbeans, more susceptible to psychosis. Yes, agreed. Are we more susceptible to dementia? We don't know the answer. Yes, yet again, everybody needs to implement those lifestyle risk factors. That is for sure. There's no statistics of this, no. Not from the Alzheimer's UK anyway, where the statistics are more robust than anywhere else, to be honest. And I would probably follow their statistics more than anyone else, because there's a lot out there on the internet which I wouldn't, really read.
Is there any statistics related to actually the environment or the organization?
Yeah, so the environment obviously plays a role. But like I said, because we don't know how dementia in general happens, we don't know the pathophysiology of dementia, it's an open game. As long as we go with those risk factors that I mentioned earlier, there's nothing to lose. Okay, so the comparison that has been mentioned is that patients obviously from well-off communities or well-off countries, are probably developed countries, you can say, are probably likely to live longer, which means we've got more statistics to say that they can, because obviously we say it's an age-related progressive condition, so therefore we have more figures from developed countries as opposed to underdeveloped countries. But whether wealth, having the money helps, probably not, no. But we have more statistics for developed countries.
It's not the money I have in mind, actually of being exposed to the environment, actually, due to the pollution. Whether the underdeveloped countries, whether they have the same rate, you say we don't have the statistics.
We don't have the statistics, no.
Therefore, whether it is really has related to the background of the way they develop, or whether they're to do with the pollution, etc.
Yeah, no, we don't know the answer to that. Unfortunately, dementia, it's at its complete infancy at this present moment in time, and when the NHS is funded with it, then maybe we'll be able to do something about it.
Assalamualaikum. What are the heritability rates?
So genetics. Okay, so genetics actually, again, we are just speculating here, But most experts will agree that with genetics, it's mainly, and I'll get a little bit technical here, is one of the genes, mutations that we have is the apolipoprotein E4. Okay, that's one of the mutations that happen. However, having said that, it plays a role. Definitely genetics play a role. But we don't have enough robust evidence to say that just because we've got someone in our family with Alzheimer's disease, we will also get that, because single gene mutation, there isn't much evidence around that anymore.
So single gene mutations is very rare for any disease.
Exactly.
I think my question is more like, what are the chances? So how much of it depends on heritability, the chances of it, not it being, for sure. I think in any mental health concern, for sure is not a term.
No, it's not.
It's very rare for it to depend on a genetic mutation, but how much of it is?
It's like saying how long is a piece of string. The answer is we don't know. Literally, that is the answer. We don't know. We know genetics play a role. We know that genetics will probably form familial Alzheimer's disease on early onset dementia, which is under 65. How much of it will it contribute? We don't have an answer.
Okay. And the other question is, are there any critical time periods? So when we're looking at depression, for example, in adolescents, we see that as they get into adulthood, there's a high percentage of them to actually carry that mental health disorder. I was just, curious about dementia. Would there be a critical time period that is a very important time for the development of the brain or the reduction of neurons in the brain?
I think it's a critical time period from adolescence onwards, really. And obviously, you have to bear in mind that because we don't know what causes dementia, okay, it's very hard to kind of gauge that in the early, adolescence period as the brain is developing, that is the time to have those risk factors really in control, or is it from an infancy when, we're still slowly starting to develop and grow? Because we don't know, all I can say is try and from the early age on.
Okay. And thank you so much for your presentation.
No
It was
worries.
very informative. Thanks.
No problem. Are there any more questions?
I think we will end there. And inshallah,
Yeah.
if you have any further
Fab.
questions, I think Rukaiya is still here, so inshallah you can ask her in person. Salawat.